Okay, so hello, my name is Yara Aldigi. Today I'm going to be giving you a short lecture about an intro to psychiatry, depression, and schizophrenia. If you find any problems with the PowerPoint or my voice, you can tell me and I'll try to repeat everything I've said. So of course, I'll try not to go into too much depth. I'll try to tell you the basics that you need to know for your level, and of course, why it's important. So as an outline, we're going to be introducing what psychiatry is, what depression is, what schizophrenia are, and then I'll be able to answer your questions if you have any. So what is psychiatry? I'm pretty sure you've heard of it as a specialty of medicine. So psychiatry is a medical field, and its importance is at studying mental disorders. So what causes them, what type of epidemiology it consists of, the types of features, the assessment, treatment, and how we could prevent these. So psychiatry provides a physician with the knowledge and skills required to recognize and deal with those mental illnesses and the patients, regardless of their field of medical practice. So what is DSM? Now you're going to be realizing that when I start to talk about depression and schizophrenia, I'm going to be bringing up the DSM criteria quite a lot. So DSM is the Diagnostic and Statistical Manual of Mental Disorders, and it's basically the handbook that they use or that healthcare professionals use to diagnose these mental disorders. So it was published by the American Psychiatric Association. We usually say DSM-5, and 5 means that it's just the 5th iteration, as in they revise it again, add or delete things they need. So why do we use the DSM? The DSM helps provide a common language for clinicians so they can communicate to their patients and establish a consistent and reliable diagnosis. So instead of every country going on a limb and deciding what this mental disorder consists of, they decided to all gather around and pick the most specific criteria for a mental disorder. So mental disorders can either be primary or secondary, as with other diseases. Primary means that we don't know the etiology. So when they say idiopathic, sometimes it can be called functional or non-organic disorders, but they all mean the same thing. So what are the examples of a primary mental disorder? You can have schizophrenia, panic disorders, and adjustment disorders. These are the disorders that are considered to not have a known etiology. As for secondary, these are the disorders that have an underlying primary physical etiology. So this could be any mental disorder that is induced by a physical disease, by a medication or substance abuse. Again, mental disorders can be described as psychotic or non-psychotic. So when we say a mental disorder is psychotic, it means that the patient's insight and reality are impaired. What does insight mean? Insight means that when you try to communicate with a patient what they have, so you tell them, you have this mental disorder. This patient doesn't recognize that they are suffering from a mental disorder. As for reality, it can manifest as delusions, hallucinations, or a severe disorganization of thought, speech, and behavior. So when I say delusions, I mean that the patient has a fixed false belief. So they either believe they're a god or they believe that somebody is trying to hurt them, so on and so forth. As for hallucinations, it means that the patient has perceptual abnormalities. So they hear things that aren't there, they see things that aren't there, and so on and so forth. As for non-psychotic disorders, they are mental disorders with intact insight, meaning that when you try to communicate to a patient, they have a mental disorder, they can recognize this. And of course, their reality is usually maintained. So they don't have any delusions, any hallucinations, severe disorganizations of thoughts, speech, and behavior. So as for our first case, I'll try to present it and just tell me which mental disorder you think it could be out of depression or schizophrenia. So a 27-year-old single woman works as a teacher. She has a 5-week history of low mood, chest tightness, a poor appetite, disturbed sleep, excessive guilt feelings, and loss of interest in her social activities. Her father has a history of a mood affective disorder. Okay, perfect. So Nora says depression, and she's completely correct. This woman is most likely suffering from depression. So what is depression? Depression is considered a primary mental disorder, as in it's usually idiopathic or we don't know the exact cause. It can present with or without psychotic features, depending on the severity of the depression. It's usually characterized by a depressed mood and anhedonia lasting for at least 2 weeks. So when I say anhedonia, what do I mean? I mean that the patient usually has, or everybody in the world usually has hobbies they like to do. Anhedonia means you start to lose your interest in these hobbies. So no matter how much you try to do them, you don't feel happy or excited to do them anymore. As for its epidemiology, they found out that women are more likely to have depression than men, and it usually affects those with a higher educational level. So, etiology. There are multiple factors that contribute to a person having depression. So you can have some genetic factors, which is supported by family twin studies. So they found out that if you have somebody in your family that has depression, you are more likely to have depression. Biological, so reduced level of norepinephrine, serotonin, dopamine. The importance of the biological etiology will come later on when we start to talk about the medications that we can use to combat depression. And of course, psychosocial. So those who go through stressful events repeatedly, or those who have pre-morbid personality factors or cognitive disorders, they're more likely to have depression than those who don't. So what are the diagnostic criteria for a major depressive disorder? When I go through them, I'm going to be going through alphabets. So we're going to go A, B, C, D, E, etc. And they're all important, and I'll try to concentrate on it more at the end. For now, I'm just going to be going through them. And of course, if there's something you'd like me to explain more, you can always ask. So for A, you have to have a depressed mood most of the day or almost every day. This depressed mood in children isn't always exhibited the same. So instead of children being sad, they could start to appear more irritable. And this is also a characteristic for depression in children. They could have sleep disturbances. Now, notice how I say sleep disturbance, which means they can either be sleeping less or more. It's not specific to one of them. Again, anhedonia, so losing interest in the hobbies a person once thought were fun. Feelings of worthlessness or disproportionate guilt, usually for no reason. Fatigue or loss of energy, a diminished concentration, cognition, and ability to make decisions. And we call this pseudo-dementia because it's not real dementia. So you can think of it as a fake dementia. During this depressed mood, people aren't able, or the patient isn't able to concentrate or to be as cognitively able as they once were. Weight changes due to appetite changes. And again, that could be seen as an increase in appetite or a decrease in appetite. It depends on the person. Psychomotor changes and suicidal ideation. When we talk about B, it's important when diagnosing depression that the patient has a significant stress or an impaired functioning in their work or in their school, etc. So for you to diagnose it as a mental disorder, there has to be some functional impairment in the patient's life. Again, symptoms have to not be due to psychoactive substances or organic diseases. Like I said in the beginning, major depressive disorder is considered a primary disorder. If it's due to substances or organic diseases, then this is secondary. The symptoms are not explained or not due to another psychiatric disorder. For example, with bipolar, you can have depression and you can have mania, which brings us to E. It's important that there's no history of manic or hypomanic disorder or episodes so we can differentiate depression from bipolar. I hope this is clear. So when I talk about A to E, I'm referring to one single episode. One single episode of depression has to have almost all of these. For us to say that it is a disorder, this episode has to be recurrent. And There has to be a gap of at least 2 months between each episode, or else we don't meet the criteria for a major depressive disorder. As for the management for depression, the initial management for adults is either considered pharmacotherapy or psychotherapy, and they can either be used alone or in combination. So for medications, like I said, in the biological etiology of depression, it could be due to norepinephrine, due to serotonin, due to dopamine. So when we try to treat a depressive disorder, we try to target these receptors. So the first line medication in depression would be a selective serotonin receptor inhibitor. And the alternatives, of course, there are norepinephrine receptor inhibitors, atypical antidepressant, tricyclic antidepressants. Usually they start with SSRIs due to the difference in side effects, so it's usually found to be better. As for the psychotherapy, the patients undergo something called a cognitive behavioral therapy, which is where they talk about the psychiatrist about these thoughts, where they come from, what things they could do to avoid going through this depressive episode. Like I said in the criteria, depressive episode or a depressive disorder has to be impairing the patient functionally, which means they can't work or they can't study or they can't go to school or function as a normal person in society. So you try to help them by giving them ways to combat this. So what would we consider hospitalizing a patient with depression? Usually this is conserved for patients who have severe depressive episodes. So they're usually at a high suicidal risk. You would hospitalize a patient if they have a medication resistance, presence of catatonic or psychotic features. So catatonic features means that the patient is exhibiting abnormal movements and reactivity. It can be just staying quiet, it could be staring, it could be that the patient is restless, so on and so forth. And then, of course, you would hospitalize a patient if you need to give electroconvulsive therapy. So what is electroconvulsive therapy? It's a procedure in which electric currents are applied externally to the skull, and it's to induce or initiate a seizure under anesthesia. It's reserved for severe refractory and or psychotic depression. So usually if all else fails and you've given the patient pharmacotherapy and you've gone through psychotherapy, but the patient still has these severe depressive symptoms, they could go under electroconvulsive therapy. So what are the indications? Like I said, schizophrenia with catatonic features or that are resistant to drugs, depression, so of course with a high suicidal risk, with stupor or marked retardation. And when I say this, I'm talking about the movement. So you see that there is slow digressing of their movements or behavior, depressive disorders with delusions, or if they are unable to take medications. So if they have any contraindication to the medication, you'd give them electroconvulsive therapy. And of course, we have other disorders. So postpartum psychosis, schizoaffective disorder, and mania can also benefit from electroconvulsive therapy. So as for a second case, I'll present it and everybody can give me their idea of what the diagnosis could be. So we have a 20-year-old single man who is brought by his father to the emergency department with a 7-month progressive history of 1, he keeps talking to himself, he keeps giggling and grimacing. 2, he keeps staring at the roof of his room. 3, over suspiciousness, so he believes that his family may poison his food, and agitation. So he's presenting with all these 4 symptoms, let's say. His past history, he has several psychiatric hospitalizations because of disturbed behavior and perception. So he either hears non-existent distressing voices or somebody commenting on his actions. So for this disorder, what do we think it might be? Yes, awesome, Rima. It's schizophrenia, or it's most likely to be schizophrenia. So what is schizophrenia? It's a primary psychotic mental disorder. It's categorized by a chronic or recurrent psychosis. When I say psychosis, I mean the patient has a distorted perception of reality. So he could have delusions, hallucinations, and or disorganized behavior. As for the epidemiology, they found that it's more likely to be in men than women, and the prevalence is less than 1%, unlike depression, which is much, much, much more prevalent in Saudi Arabia and, of course, in the outside world. So what is the etiology of schizophrenia? Of course, it's a primary disorder, so we don't know what exactly caused it, but we have different theories. So you have genetic factors, and they studied this and found that there is a single gene on chromosome 11 that could be the cause of schizophrenia. Of course, this is speculation. Neurobiologic, so dopamine, serotonin, glutamate, and GABA hypotheses. And of course, there are different articles going into more depth, but it's just important to know that these hypotheses exist. Again, neuropathology, neuroimaging. So on CT, MRI, and PET, they found abnormal features. And they thought that this might be contributing to a patient's disorder, or if they have the disorder or not. And then psychosocial and environmental, so life events. If a person goes through recurrent life stresses, and particularly in the 3 months prior to the first episode, this can induce schizophrenia in those who are found to be vulnerable. So what are the diagnostic criteria for schizophrenia? According to the criteria that we have, it says that a person has to have 6 months or more duration of a disturbance. And during this 6 month, we need at least a month or more of psychotic features. These psychotic features can present with 2 out of the following 5. So delusions, hallucinations, disorganized speech, disorganized behavior, catatonic features, or negative features. Like I said, in depression, we have a B, C, D, and E, which means it has to be B, functionally impairing either their work or college, university, etc. It has to be not due to a different psychotic disorder or a different mental disorder. D, it shouldn't be caused by psychoactive substances or medication. And only then can we diagnose it as schizophrenia. So in schizophrenia, we have acute versus chronic. The acute type of schizophrenia is usually categorized by a presence or by positive features. So the patient with acute schizophrenia has prominent delusions. They have prominent hallucinations. They have disorganized thinking and speech. They have disturbed behavior and incongruity between affect, thinking, and behavior. Incongruity just means that there's a mismatch between the way they think and the way they behave. In chronic schizophrenia, we have a lack of features, or we have negative features. So the patient doesn't have good self-care or hygiene. They don't have initiative or ambition. They have social withdrawal. They don't have enough thoughts and speech. So when we say poverty of thought and speech, it means when you try to communicate or talk to them, they reply with a word, or they might not reply at all. Restricted or apathetic affect. So by affect, we mean the patient's emotions or their ability to express these emotions. They may have cognitive deficits, loose associations, or word salads. So loose associations means they start to talk about topics that have no association to each other. So here it's loose. Word salads means they just kind of say things that don't make sense, or inappropriate words that don't usually go together. And then, of course, delusions and hallucinations are less prominent than in the acute phase. So for schizophrenia, there are things that we can see in a person or in a patient. We can say, okay, this means, or hopefully this means that this patient has a good prognosis. So when would a patient have a good prognosis in schizophrenia? Usually if they have a late onset, so if it comes during the later ages, so more in the 30s, we can say this person or this patient has a better prognosis. If it's more acute in onset, if there is an obvious precipitating factor or a trigger, if there was a good premorbid personality, of course, presence of mood symptoms. So if the person has schizophrenia, but it has also symptoms of depression, this is considered a good prognosis. Presence of positive symptoms and good support. All of these factors contribute to a better prognosis in a patient with schizophrenia. What I considered bad, so of course, the opposite of what we mentioned before. If a patient has had schizophrenia at a younger age, they perceive it as having a bad prognosis because as the years go by with a chronic illness of schizophrenia, the patient is more likely to get worse. So the younger you get it, the worse it might be at a later age. A more insidious onset, or if we don't know what the triggering factors are, poor premorbid personality, a low IQ, having many relapses during these months is considered bad. No remissions in 3 years. So by remissions, I mean you have an acute phase or you have a chronic phase, and then it stops for a period of time. So if it doesn't stop for a period of 3 years, this is considered bad prognosis. Poor compliance to medication, of course, negative symptoms. Like we said, in chronic, you have a lack of hygiene, lack of self-care, and etc. A family history of schizophrenia is found to have a worse prognosis. Okay, so what are the general considerations that a physician has when working with a patient who has schizophrenia? So it's important to establish a therapeutic alliance when you're taking care of a patient with delusions. So alliance means that the patient has to consider you their friend and not an enemy. So you have to acknowledge the patient's emotional state, and you have to avoid either validating or confronting a patient's delusions, and of course, the nature of symptoms. So if you try to bring it up to a patient with schizophrenia that these delusions are unreal or that they don't exist, this is considered confrontation. As a physician, of course, you have to avoid these confrontations so you can establish a therapeutic alliance with the patient, and it's better for the patient's compliance, and etc. The initial response to medications in schizophrenia usually takes 2 to 4 weeks, and it's associated with a better long-term response. Hospitalizations in schizophrenia, you'd usually hospitalize a patient if they had an acutely psychotic episode. So if they were acutely aggressive, or if they had very spontaneous behaviors, or if they were harming others around them, you would consider hospitalizing them. As for the pharmacotherapy in schizophrenia, during an acute psychotic episode, patients or physicians give patients short-acting antipsychotics. So these are considered like atypical antipsychotics, which are usually given. So clozapine, olanzapine, and risperidone. Usually, if they have an acute manic episode, you could give them mood stabilizers. The first-line treatment in schizophrenia is considered second-generation antipsychotics. So risperidone and quetiapine, and they are usually effective at treating positive psychotic symptoms in a patient. I try not to go too into depth with the medication because it's very advanced, but it's important to know that the patients are giving second generation antipsychotics as opposed to first generation, since they are more toxic. During acute psychotic episodes, you have to give short-acting antipsychotics. So these are the references that I used. Does anybody have any question or anything they would like me to elaborate on? You're most welcome. Thank you for listening. And this is my email, my contact information if anybody needs anything. Thank you.
يعطيكم العافية جميعا. أرسلت رابط الكويز بالشات.